So moving on to blood dyscrasias, which are the disorders that involve the cellular components of the blood. So we'll start off with the anemias. They all pretty much present similarly, and anemias result in a reduction in the oxygen transport, or reduction of it. So we have less oxygen. So the basic problem usually all boils down to hemoglobin deficiency. So there's not enough hemoglobin for one reason or another. So overall we see systemic symptoms where there's less energy in all cells, so their cellular metabolism and production is diminished. We try to compensate by increasing our heart rate, which is tachycardia, and also we might have peripheral vasoconstriction. The general signs include fatigue, pallor, pale face, dyspnea, which is shortness of breath, and tachycardia, which is elevated heart rate. The oxygen deficiency also leads to things like the decreased regeneration of epithelial cells. So epithelial cells divide pretty rapidly, and they help protect us and line and cover the cavities and the tubes in our body. So we can see the digestive tract become inflamed and ulcerated. We can see that and lead to inflammation of the stomach, stomitis. We can see inflamed and cracked lips. That's another epithelial tissue. Dysphagia, where there's difficulty swallowing because inflammation in the respiratory tract and the pharynx. And then we can see that the hair and skin may have degenerate changes. Even severe anemia can lead to angina, heart pain, and congestive heart failure. The first type that we'll talk about is pernicious anemia, which is a vitamin B12 deficiency anemia. With pernicious anemia, we don't absorb enough vitamin B12, and this pernicious anemia is because of a lack of the intrinsic factor. Intrinsic factor is made by the gastric mucosa in response to the hormone gastrin, and it's required for us to be able to absorb vitamin B12. Since we have low levels of B12, this is characterized where the red blood cell, B12 is very important for cellular division, so let me just say that. And since the cells can't go through the process of division, we end up with erythrocytes, red blood cells, that don't completely mature, and they stay as large, immature erythrocytes that can even keep their nucleus. And if you remember, your erythrocytes, they don't have a nucleus. So we don't make enough hemoglobin because we don't have enough B12, and we also have a shorter lifespan of the hemoglobin that we do make. Pernicious anemia is due to the lack of intrinsic factor. It's usually not caused because we usually get enough vitamin B12 in our diet. But if it does happen where we don't have enough B12 in our diet, that could be another cause. Most of the time it's because there's been damage to the cells that produce the intrinsic factor, like ulcers and things of that nature. There are some genetic factors that seem to affect pernicious anemia, such as those it's more common in light-skinned women of Northern European ancestry. It often accompanies chronic gastritis, which is where we have inflammation of the stomach, where there's damage to the cells of the stomach, and that's usually where we get the damage to the cells that produce the intrinsic factor. If you remember, the cells that make the acid, which are parietal cells, also make the intrinsic factor. And it also can be an outcome of gastric surgery where the cells are damaged through the surgery. So normal erythropoiesis, the vitamin B12 is ingested in the food. The parietal cells produce the intrinsic factor. We can absorb the vitamin B12, which will go to the bones, and this helps with the maturation of the erythrocytes, and we have normal erythrocytes. But with vitamin B12 deficiency, for some reason, we cannot make the intrinsic factor, Sometimes it can be done. Antibodies can cause problems. So no absorption of vitamin B12, and then we can't make our mature red blood cells. And we often see with B12 deficiency, the red blood cells that are made are overly large with nucleus, and those are megablastic erythrocytes. They don't mature, and they just get really large. So vitamin B12 deficiency, we don't see a whole lot of red blood cells, and we see some red blood cells that still have their nucleus, so they're not mature, and they're overly large because they should be a lot smaller than this white blood cell here. Manifestations, in addition to those, the typical anemia. So what is extra? Well, the tongue is typically enlarged. It's red, sore, and shiny. So we see a enlarged tongue. There's usually some kind of digestive discomfort, often with nausea and diarrhea, because it does affect the digestive tract. Tingling and pins and needles in the limbs. Diagnostic tests are through microscopic examination, where we can see the erythrocytes. We can examine the bone marrow and see if it's hyperactive, trying to make red blood cells but can't. And we can look at the vitamin B12 levels to see if they're low. Sometimes we can see the presence of hypochlorhydria and achlorhydria, and that indicates there's a lack of there's a gastric atrophy where the stomach is deteriorating. The next type of anemia is aplastic anemia, and this comes from the impairment or failure of the bone marrow. So the bone marrow is damaged. It can be temporary or permanent. It's often idiopathic, which means we don't know the cause of why all of a sudden we get this aplastic anemia where the bone marrow is not functioning correctly. Some causes that could be possible are myelotoxins, which are toxins that affect the bone marrow, and that include things like radiation, industrial chemicals, and drugs. Viruses have shown to be more prevalent, especially hepatitis C, and then also some genetic abnormalities can lead to myelodysplastic syndrome of Fanconi's anemia, which are genetic. This is where the red blood cell, the red bone marrow is not functioning, and it fails to produce the cells. What we see is the blood counts often indicate pancytopenia, which is an increase of all the blood cell types. A decrease in all the cell types, the red blood cells, white blood cells, and the thrombocytes, so they're all low. So everything's in a low amount, and biopsy of red bone marrow may be required. The red blood cells that are made often appear to be normal. They're just going to be in a lesser amount, along with a lesser amount of all the other blood cells in the blood. Identification of the cause, if we can find it, if it's not idiopathic, and prompt treatment is needed for recovery. If possible, if there aren't any bone marrow suppressants, please remove. And also, if we can't, a failure to identify the cause or treat effectively, it is life-threatening, because if we can't make enough red blood cells, we will die. The next type is a hemolytic anemia. This is where the red blood cells are destructed. They're destructed prematurely, usually. There's genetic effects that cause this, that cause them more likely to be destroyed, such as sickle cell anemia. We can also have these immune reactions where we attack the red blood cells and cause the lysis of the red blood cells, where they're destroyed. Changes in the blood chemistry, we can see it in infections like malaria, because the parasite goes into the red blood cells, and when they are burst, they're released. Toxins in the blood can cause hemolytic anemias, And then there's also the antigen antibody reactions, which is the type 3 immune response. And this occurs, type 3 hypersensitivity immune response. And this occurs with incompatible blood fusions, or if the mother is Rh negative and the second child is Rh positive, she can have an antibody antigen reaction. So all these things result in the lysis, or the destruction of the anemia of the red blood cells, and therefore we have less red blood cells. Let's see. The one that I kind of left off that would be worth talking about for just a second is the most common one, which is the iron deficiency anemia. This is the one where we have low iron, and then since we don't have the iron, we cannot make the enough red blood cells. Usually it's because of dietary intake or blood loss. So we see iron deficiency anemia more in females because of the menstrual cycle, and they lose blood each month. And this also, what we see is through the red blood cells that are often smaller and have a decreased amount of hemoglobin production. Okay, and then pernicious anemia, which is a vitamin B12 deficiency caused by deficiency of intrinsic factor, aplastic anemia, damage to the bone marrow, and then sickle cell anemia, which is the hemolytic anemia, which is due to genetic inheritance. The next blood dyscrasia is polycythemia. Then we have primary polycythemia and secondary polycythemia. Primary means it's caused by the bone marrow production, and then secondary polycythemia is because it's caused by something else. So polycythemia vera, which is the primary, is where we increase the production of the erythrocytes and other cells in the bone marrow. So we're making too much. And this is a neoplastic disorder, which is like a cancer. It means new cells being made. It's more of a time like a cancerous type of situation, but it's not cancer. It means it's just making more and more, and it's not responding to the hormonal controls. So the bone marrow is making it regardless. It's not following the hormonal controls like erythropoietin for the red blood cell production. So the hormonal levels are low, but we're still making too much. And then we have secondary polycythemia, or erythrocytosis, in which we're making too much red blood cells. And this is due to the hormonal levels being too high. So the hormonal control center, homeostatic control for erythropoietin is off. With primary, the control part is off in the bone marrow. Okay. With the secondary, it's due to the erythropoietin secretion. Normally, one way it acts as a compensation mechanism to increase oxygen transport. For example, if a person is in prolonged hypoxia, which means low oxygen levels, maybe they're up on Mount Everest. Okay, we're increasing the erythropoietin, which will in turn increase the red blood cell production. Or for other reasons, maybe they're a smoker, and so that they always have low oxygen levels. So it does the same thing. With secondary polycythemia, you need to treat the underlying cause of why they have too much red blood cells. Some signs and symptoms include distended blood vessels or sluggish blood flow, too many cells, increased blood pressure, hypertrophied heart, which means the heart gets larger, trying to have to pump harder, hepatomegaly, which is the spleen enlargement, the liver enlargement. Splenomegaly is spleen enlargement, dyspnea, difficulty breathing, headaches, visual disturbances, and then clots and infarctions. Thrombosis is your clots. Infarctions is where we have cellular death due to low oxygen levels. Diagnostic tests often include looking at the red blood cell counts and the cell counts, hematocrit values, and then, if necessary, do a bone marrow biopsy to see if there's hypercellular, more cells in the bone marrow, and then also if there is increase in uric acid in the blood, hyperuricemia. Treatment: identify the cause, whether it's the bone marrow or from the erythropoietin, which could indicate a tumor. You can treat with drugs and radiation, which is going to help suppress the bone marrow activity. And also periodic phlebotomy, which is where we're going to drain off some of the blood because it's getting too thick, and so to help bring down the amount of blood that's being passed through the body. Next up, I'm talking about the blood clotting disorders. This is where usually there's some factor missing out of the blood, so the blood doesn't clot correctly. So signs and symptoms indications include bleeding from the gums, repeated epistaxis, petechiae, which are flat pinpoint spots on the skin and mucous membranes, frequent purpura, which is like a purplish rash where blood is, and ecchymosis, which is a discoloration due to the blood. You often see more bleeding than normal in trauma, and then you can also have bleeding in the joints, which are hemoarthritis or arthroses, where there are rhamnocytes, and also coughing blood, hematotesis, and then throwing up blood, hematoemesis, where the blood is thrown up, is vomited, and it looks like coarse brown particles, almost like coffee ground. Emesis. Also blood in the feces, which could be black, which means it's closer to the end of the digestive tract, or occult, which you can't see it. Occult means you can't see it. There can also be anemias due to constantly not having low red blood cells, feeling faint or anxious, low blood pressure, and a rapid pulse to compensate. Here's our petechiae. You can see all the little dots, meaning that there's a little break in blood vessels. One type that is pretty common is von Willebrand's disease. This is common. There are three major types of this von Willebrand's. Depending on the type, it determines how significant the disorder is. There are signs and symptoms include skin rashes, nosebleeds, breezy bruising, bleeding of gums, abnormal menstrual cycle. The severity and the type is going to determine the treatment for these clotting disorders. You have to be really careful with the clotting disorders. If a person has them, you have to be prepared. A lot of times you have to give them some kind of clotting factor to treat the clotting. The next disorder is called disseminated intravascular coagulation. This is where the blood abnormal clotting. It's the opposite of, so with the blood clotting disorders, you have difficulty with clotting. Okay, with the disseminated intravascular coagulation, we have too much clotting. Okay, so with this case, you have a cycle. Okay, so the cycle involves excessive clotting, and what happens is most of the clotting factors get used up, and then that makes the clotting factors low. So you have excessive clotting, and then you have low clotting factors, which leads to excessive bleeding. And so we end up on this really terrible cycle where we have excessive clotting, where thrombi and infarcts occur. Thrombi is the clots, and infarcts are the death of the cells. And then they're reduced because we had so much of it. And then after they're reduced, we have uncontrollable hemorrhage. Okay? And So we have the bleeding, clotting, bleeding, clotting. This has a very poor prognosis rate because of the cyclical measure and with a high fatality rate. The complication of many primary problems, such as obstetrical complications, such as during pregnancy, can lead to the separation of the uterus and the placenta, infections and carcinomas, and then major trauma. So all these primary problems can end up causing this coagulation and clotting to occur, and then lead us down to this disseminated intravascular this cycle. So you lose all your, like even with a major trauma, you use up all your clotting factors and your clotting mechanism, and then there you're susceptible to excessive bleeding. So you can see the process. There is some kind of extensive endothelial damage or the release of the tissue thromboplastin, and this initiates the clotting process. So we have a lot of thrombi form, they get used up, and a lot of thrombi, and then it causes ischemia and multiple infarctions. But at the same time, since they're using up the clotting factors, we end up with thrombocytopenia and decreased serum fibrinogen. The fibrinogen helps with clotting. So these are low. Along with, when we break down the clots with the healing process, is going to end up with the second part of this cycle, which is excessive bleeding and hemorrhage. So all this can lead to organ failure. Okay. I think the last one we're going to talk about is thrombophilia. This is inherited or acquired disorders. This is where we get abnormal clots in the veins and arteries. When we test for this, we're looking for abnormal clotting factor levels and antibody levels. The underlying treatment condition should be treated.